it. Please, if you want to grab one and show your support for colorectal cancer awareness for the rest of the month, please do. We have plenty at the table here. Were there any other pre-questions before we start? We have people, drifting into the church and about to join our Zoom, and then we'll get formally started.
Yeah, I got a question.
Sure, Bill.
In your practice, have you seen because of the COVID more people coming into the hospital because of that?
Yes and no. Obviously, more people are coming to the hospital or at the time when COVID was in high gear, there were definitely a lot of people coming to the hospital for acute illness and for treatment. For kind of general primary care, well visits where you're just coming to see your doctor for routine care, that did have a bit of a lull during the peak periods of COVID. Just because of the restrictions and social distancing and the inability to be in waiting rooms and things like that. In our field in GI, we did slow down our procedures, particularly things that were not emergencies, that are not, therapeutic and life-saving. So just our routine screenings, we did slow down on those for a little bit, but we have picked up now and things are getting back to normal.
Thank you.
I just want to add that we are doing screening colonoscopies, and I think most places, if not all, are providing safe environments. Everybody is masked. We try to stick to the 6 feet of social distancing. So if you really need a screening test, you should not delay it. You should go ahead and get it scheduled. And the numbers are really going down as well. I'm seeing less than 2% positivity rates each day. So I think by the summer we're going to get there as more people get get vaccinated.
Thank you, Bill. All right, so it's 10:30.
Okay. So we go back to screen share.
And then click on the left where it says
This one? Okay.
that's the one. Double click on it.
Okay.
And then you'll see you're now sharing your screen. So
Okay.
How do I get hit this one?
you want slideshow.
Oh, slideshow. Use slideshow?
There you go.
All right. So, as you know, March is Colorectal Cancer Awareness Month, and blue is the color that we use to signify colorectal cancer awareness and prevention. It is a screenable disease, it is a preventable disease, and it is a beatable disease, and it's something that we feel very strongly about and hope that we can inspire you guys to, if you're of age or if you have certain risk factors in your family, to go ahead and get a screening test. There are many, many modalities for screening, but we hope to show that colonoscopy is it's the gold standard that we have nowadays for colorectal cancer screening. So just in terms of some background on the epidemiology of colorectal cancer, I looked at the 2018 Globicon, that's a global number of cases worldwide. There's about 2 million cases per year worldwide. And of that, there's going to be about close to 650,000 deaths per year. In the US, this is now the 5th most common cancer, but if you look at the epidemiology back in the 1980s and 90s, it used to be the 2nd most common cancer in this country after breast in women and prostate in men. So through our efforts, our intensive screening programs, and the US is one of those lucky countries where we do have high rates of screening, we've brought that down to the 5th most common cancer. So screening is effective and life-saving. In terms of age, the incidence does increase with age. So if you're over 50 years old, 90% of the cases will come in patients who are over 50 years old, but we have been noticing an uptick in people who are younger. So the new recommendation guidelines are actually starting colorectal cancer screening if you're average risk at about the age of 45. There is disparities in the incidence of this disease, and race and ethnicity sort of increase your risk factors. So the highest risk is in non-Hispanic blacks, and we think the lowest risk is in Asians. So, how do I have to click?
I have to leave this to,
How do we move forward?
do we have to
Slide.
exit this to, because it's not,
It's not letting me.
maybe we have to exit the.
We want to move the PowerPoint.
Oh, here, maybe this? Yep, there. So this is the 2020 data, and this is just data in the United States. In the US, in 2020, there were almost 150,000 cases of colon cancer. And again, there is an uptick in the younger group because they weren't being screened, the 45 to 50-year-olds, but the new recommendation guidelines are to start screening at 45 because in the less than 50-year-old group, there were almost 18,000 cases. And in terms of colorectal cancer, this is an equal opportunity disease based on gender. So the prevalence rates are equivalent in men and women. In terms of the lifetime risk, about 1 in 23 males and 1 in 25 females will be at risk for developing colorectal cancer in their lifetime. That's about a 4.4 or 4.1% risk. Again, the highest incidence and mortality is in non-Hispanic blacks, and the lowest is in Asians.
Wow.
So this is just historically looking at the rates before we implemented intensive cancer screening programs. So again, there was an uptick in the 70s, 80s, really up until 2000, and sometime around 2000 with these screening programs, you start to see a sharp decline in the number of incidence of cases and mortality from this disease. Again, this is just showing the same thing. Again, you have an uptick up until sometime around 2000 when the screening programs become intense, and then the numbers start to drop off drastically. Again, you're moving from the second most common cancer to the fifth.
I have a question.
I'm sorry?
I have a question.
Yes.
Was the increase in males because they tend not to go to the doctors?
It's possible. I think historically, females tend to be more proactive, care-seeking than males, but the numbers are just so low. You know, it is equal incidence in both. It's not one disease that's prevalent to one gender versus another.
That's just something I noticed on the screen before. Males looked like it was a higher incidence than females.
Yeah, and that could be because they're not seeking care as often
Right.
as females are, or as vigilant about it.
That's what I thought. I just wanted to ask.
Yeah. So this is just another figure that I saw recently. Again, if you look across all age groups, the incidence is decreasing, except in this 45 to 49-year-old, where the incidence is going up. So again, the recommendations have just been revised more recently, starting at around the age of 45. And I'm going to turn it off to Dr. Okpara now.
All right, thank you. So, you know, we're going to kind of get to the more technical aspects and more diagrammatic issues with colon cancer, and hopefully this can address some of the questions that people have about colonoscopy and about screening and why they need to do it and how it's done. So as my colleague did mention, colon cancer is related to the growth of what we call polyps. They're these little growths, and I have this diagram over here. If you can see, it starts as tiny little bumps. You don't feel them, you don't see, know that they're there, but over time they get bigger and bigger, and then they start to eat through the wall of the intestine, and then this blue arrow shows those bad cells spreading over to other organs and causing metastatic disease, which is what we want to prevent. So for prevention of colon cancer, some of this is no-brainer, right? Healthy habits, avoid smoking, avoid processed foods, charred meats, darkly charred red meats. Alcohol, obesity is also a risk factor. A lot of people are unaware of that and the association of that with colon cancer. And then screening. So, what does screening mean? Screening means you're looking for disease in the absence of symptoms, right? So this is healthy people just checking and checking early in order to prevent the bad effects. So for colon cancer, there are different modalities for screening, all right? The goal is that you do something rather than nothing. Now, obviously, some screening methods are preferred and are better than others, but we're gonna go through a few of them here just so that people know that there are options. So this first line over here shows what's called stool testing, and there are different modalities for doing that. The FOBT is the stool fecal occult blood test, and that's where you just submit a stool specimen either on a card, and it gets checked for blood, which can be a sign of early cancer or large polyps. FIT stands for fecal immunochemistry test, which is also looking for advanced markers of large polyps or colon cancer. And then a lot of people are probably familiar with what's called the Cologuard. You may have seen that dancing box on the TV, hopping around. I'm this screening test for colon cancer. You don't need to go to the doctor. You don't need to do anything. Just send in your stool specimen. And what these stool tests are able to do is to detect cancer or large polyps. They're really not good for the really small polyps, but at least, when you are probably on the edge of getting to serious disease, they may be able to detect this. The key word here is to detect. They can't do anything about it. If you end up with a positive test, you still have to go on to do a colonoscopy in order to follow up that finding and hopefully take care of it. The next line there is the CT colonography. There are some X-ray type of tests or CAT scans that can also, again, look for large polyps or cancer. And again, these are just detection tests. If you do see something on these tests, if they come positive, you still do need to follow through and get that colonoscopy. And then obviously we're going to talk about the colonoscopy, which is proven to be the most efficient way to prevent colon cancer. It can detect both large as well as very small polyps. We've gotten to very advanced technology that can detect the most minute of polyps. And the beauty of the colonoscopy is you find it, you take it out right there and then, end of story. Okay. We'll talk a little bit about, or I'll just mention some treatment options, because obviously if you find cancer, you want to do something about it. Surgery is an option. We do have some of our surgical colleagues that are probably going to be joining us soon or on the Zoom. And we do frequently refer our patients when we do find cancers at colonoscopy for surgical treatment, depending on their stage. Chemotherapy is an option, and then obviously radiation therapy, again, depending on the stage at which you detect it. So again, just looking at our little pictures here, this is an example of a polyp. This is kind of a medium-sized polyp, and we frequently see things of this size, which at colonoscopy is pretty easy for us to take this off. Right there where you're at the test, we take it off, zip, and it's gone. What we do not want to see is this. This is the dreaded tumor, which the goal is to find things when they're at this stage, because once they're at this stage, we cannot take them out at the time of colonoscopy. At that point, we need to evaluate you further and probably send you off to surgeons for further treatment and potentially for chemotherapy and radiation. Oh, okay, we need to mute.
Yeah, that's why
Yeah, we're hearing conversations. How do you mute? It's gonna mute me. I need to mute all.
big. You have to change it every time. That how when you get it, your poop, but just so you're not streaming, it just comes out.
Alicia.
Yeah, it will come by itself because now that
Right? Yeah.
you gotta be so well in now to be in the bathroom to change it and
Where's Brian? Yeah, I can't see. Just mute it. Okay, good.
There may a gallery view that you could do.
It just gives you the.
Otherwise, we're gonna exit out. And come
Yeah,
back in.
okay, that's fine, I think we got the main talkers. All right, so what are signs and symptoms to look for colon cancer? So I start first here with the advanced colon cancer signs because, you know, these are the things that you could possibly see that could be a sign for which to seek help, all right? So a change in your bowel habits, what we say here is a new diarrhea or constipation. You're generally, I used to go once a day, all of a sudden I'm going every 5 days, or I'm going 3, 4, 5 times a day. Those are things for which to seek care. Rectal bleeding is a common one. Blood should typically not be coming from the anal area. Unexplained weight loss, fevers and chills, anemia, specifically the iron deficiency type, which suggests that you may be losing blood internally, and evidence of a bowel obstruction such as pain in the abdomen, throwing up, or distension. So, but what about early cancer? What are the signs of that? And so you see I put here in bold letters, well, that's no symptoms, right? So that's why you need to do screening, because by the time you develop symptoms, it may already be advanced and require a higher level of therapy. One of the most common questions that I get when patients come just for office visit before scheduling a colonoscopy is, you know, hey doctor, why do I have to do this? I feel fine. Why are you making me do this test? You know, again, this is a screening test. We expect you to feel fine because we want you to stay feeling fine. By the time you start to feel sick, you know, that's a sign that things have gone beyond the point where we could potentially take care of them easily at the time of colonoscopy. So if there's one take-home message that we'd like everybody to go with today is don't feel confident in the fact that you feel perfect. Once you hit the screening age, which is now 45, you need to go into your primary care for a referral to a gastroenterologist and preferably for a colonoscopy. Again, there are some other modalities that you can pursue, but colonoscopy is what we would suggest. So I put up here just some other things that may influence your risk for colon cancer. We've talked about the general risk for males and for females, but there are some other things that if they are in your repertoire that you probably will need to seek earlier care. And that includes heredity and a medical and family history. I'm not going to go through all of these bullets, but if you have a family history, that may suggest that your risk for colon cancer is higher, specifically if this is a first-degree relative. What does first-degree relative mean? That means immediate family, your parents, your brothers, your sisters, your children. If someone within your immediate nuclear family has suffered from colorectal cancer either at any age or at a relatively young age, which is before age 50 or age 60, that should prompt you to come in at least for your first screening at an age earlier than that which is recommended for the general population. If you have more than one first-degree relative, then absolutely you need to get in, you know, way earlier for your screening, again, regardless of symptoms. If you have 1 or 2 second-degree relatives, that means grandma, cousins, aunts, those type, the risk does come down a bit less. It's not 0, but it's not, in some guidelines, enough to require you to do anything more than the average risk screening. Inflammatory bowel disease is, people may have heard of things like Crohn's disease or ulcerative colitis, which are chronic diseases that can increase your risk for colon cancer. And so patients with that history also need to start their screening early. And some other more chronic diseases like diabetes and the male to female ratio do potentially increase risk, but not significantly. That second category there is what we call the modifiable factors. Those are the things that you can do to decrease your risk. Obviously, you can't change your family or where you were born to, or even in certain chronic diseases. But things like your alcohol intake and your body weight are things that you can, and your diet, and smoking obviously are things that you can modify to decrease that risk. At that very bottom category is things that you can actually do also to decrease your risk, which is increase your cardio exercise and potentially your dairy intake. So again, our message is get screened. Ask your doctor about the different screening options, all right? Something is better than nothing. These societies have now recommended that the colorectal cancer screening age be changed from age 50, which has been the standard for many years, now to age 45. Again, for those that are considered average risk. You are average risk if you do not have a significant family history or a certain chronic disease that predisposes you and increases your chance for colorectal cancer. And again, if you do have a family history, get in to see your GI doctor or talk to your primary doctor about getting screened even earlier than age 45. So this was an older slide. I did still have in there start at age 50. We're waiting for this to really become prime time. The new recommendation is age 45 for all average risk patients. It was initially age 45 for blacks. We are anticipating that could potentially also be lowered to even lower than 45. And then again, if you have a positive family history at age 40 or less than that. So this picture here is kind of showing what we do every day, all right? So this is me, Mariam, and this is our patient here. And so how this colonoscopy is done is we have a video camera that gets inserted and passed through the entire length of the colon, which is a pretty long tube. It's about 5-6 feet. It does have angles and turns and bends. So we do sedate patients. We give you a light anesthetic, just makes you sleep lightly, and then we look. And we are watching here on a computer screen looking for these little polyps. So this is an example of our view. And this is something that we could see on that computer screen as we're going along. And we take it off right there and there. The average colonoscopy lasts about 20 minutes.
20 minutes.
25, tops 30. Say that again? I am sharing it, yes. Can you see it? Over there? Okay. So there is, I think the part that does get people the most flustered or afraid to do a colonoscopy is the dreaded preparation. Now, in order for us to do this test efficiently, the colon does have to be cleared of its contents, which is usually stool. And there can be a lot of stool sitting in the colon, for that entire 5-6 length, 6 feet length. And so to do this test, you do have to do a little bit of work the day before the test to get this colon cleaned enough. It involves a clear liquid diet the entire day before. Usually you should not eat anything solid, just clear liquids. And then you start with some medications, some laxative type medications that will get the bowels moving, and pretty much you'll get a lot of diarrhea just for that day and everything will clear out, and then you come the next day for your test. Another potential limiting factor to some people is the fact that we have to sedate you, but a lot of people prefer that. I mean, we would like to be sedated. It's a light sedation. It's usually not anything that impairs you the next day, but it does require that you have a designated driver, somebody to drive you home that day. You cannot drive after having receiving medications, and obviously you do have to take a day off of work. Oops, sorry, let me just go right back to that. So on that first exam, really, if you do it and you do it well, and you're an average risk person, you don't have to do anything for 10 years. That includes the stool blood tests or any of the CAT scan tests, nothing. If you do your colonoscopy and do it adequately every 10 years is the recommendation. So I think it's worth it to go through it and just kind of get it out of the way for an extended period of time. If, however, you do have polyps present, depending on the type, the size, the number of them, that interval may start to cut down to about every 5 years, every 3 years, every 6 months. It depends on what's seen on that initial exam. Okay. Let's finish up.
Yeah, so I'm just going to take this last slide, and this is just a slide showing you how the different tests compare to one another, how sensitive, how good is that test for picking up disease in the face of disease. And so colonoscopy is the gold standard, like Dr. Nnenna said, because you can find polyps, you can find small polyps, you can find medium-sized, you can find large polyps, and you can take them out. So in terms of the sensitivity, the first column is little tiny polyps, less than 5 millimeters. We're looking at a 75% sensitive rate for picking those up. Obviously, as the polyps get bigger, they're going to be easier to pick up. So by the time you have polyps that are advanced or more than 1 centimeter, you're looking at about 95% sensitivity for A, finding those things, and B, removing them. So like Dr. Okpara said, any test is better than doing nothing at all. So if you're not inclined to get a colonoscopy this year, then go and get a stool card. So the second column is just looking at doing a simple stool card. And you're going to do that every year. Smaller polyps don't bleed. You're not going to get bleeding until you get to medium large polyps. So you can see the drop off. It's only about 7% sensitive for picking up small and medium sized polyps. Even big polyps, only about 23% sensitive. Really the best for looking at is cancer, right? That purple column is cancer, and at best it's about 73%. So it's going to miss about 25% of colon cancers itself. The next column is looking at the radiographic studies, and again, those are a little bit better. You're looking anywhere from 57 to 84% depending on the size of the lesion. With the colonography, which is a CAT scan, you are being exposed to radiation, and you are doing a bowel prep. There is a small bowel prep involved with doing the radiographic studies, and if they find something, you're going to have to go and get that colonoscopy done to actually see what's in the colon. The occult blood is sort of a little bit better, similar to the FIT testing. And then finally, the Cologuard, which is a stool DNA test. It's looking for abnormal DNA in your stool, and they combined it with a stool card. It's only designed to pick up advanced polyps and cancer. It's not designed really to pick up small polyps. And I have to say, I'm not a fan of the Cologuard test because what they don't advertise is that there is a false positive rate on this test of about 10%. It does go up with age, so about 10 to 15%, where the test will come back positive, and oftentimes we have gone in and looked and there's nothing in that colon. So I think it creates a lot of anxiety for patients, and they have to eventually go and get a colonoscopy anyway if the test is positive. So really, and obviously we're biased, but in this day and age, the gold standard is getting a colonoscopy. But again, if you're not inclined to do it, do something rather than nothing.
That's our take-home message. Thanks for your attention. If anyone has any questions, please feel free.
Why don't you take the screen sharing?
Stop sharing? Okay.
Okay.
Dan, if you want to ask a question.
Okay, come take the microphone, Dan. You're on the spot.
So you've lowered the age from what used to be 50? Was it that? It's now down to 45. Is that due to our life changing or our dietary habits, or that you've just found more of this kind of problem in younger people?
I think the epidemiology of that is still being studied. I don't know if there's more alcohol consumption or meat consumption or something environmental or family history. They're still working it out. But there is a good incidence rate in those younger folks, enough that they lowered it. I think it's still being worked out. I don't know if you guys know what the actual risk factors are, and they may not ever come up with one specific risk factor for why it's going up in the younger age group, whether it's something environmental coupled with family history.
Yeah.
And also, if you've had cancer within your system, are you more prone to have colon cancer if you had cancer somewhere else?
That's an interesting question. That's a very good question. I think typically not in the absence of a genetic disorder. So there are certain cancers, such as genetic disorders. There's something called Lynch syndrome that comes to mind, where you have a certain genetic mutation that puts you at risk for multiple cancers in multiple family members. So things like colon, but uterine cancer in women, ovarian, bladder, kidney, stomach. So often when I take the family history and I see somebody has colon cancer, I will ask about those other cancers in several generations, because you may be looking at a genetic syndrome. If it's isolated and you're in my patient, it's often not associated with other cancers.
Anyone on Zoom? Yeah. Yeah. Okay, yep. If you have questions, you can put it in the chat or you can just unmute yourself and speak up.
I have a question. Someone told me that Rhode Island has the highest rate of colorectal cancer in the United States. Is that true? And if so, why?
That's a good one. I can't say I've heard that. The highest rate of colon cancer in the U.S.
Yeah.
for Rhode Island? Chris, no?
Just a little bit, we don't know if it's got the highest rate, but all solid tumors are somewhat increased in this area. I think in the sort of the Rhode Island, Connecticut, et cetera, I think it's maybe related to some of the manufacturing, dyeing industries, jewelry industries, mills from Long Island. There's a slight increased risk in some solid tumors, including colon and gallbladder types of tumors.
Did everybody get that? I think you may need to.
Well, just restate it.
Yeah, you
Oh.
can just restate it, because the Zoom will disappear.
Oh, okay. So, yeah. So there is a slight risk, not specific, we don't know the exact amount, but for all solid tumors, there has been noticed an increased trend, and not just in Rhode Island, but in some of the surrounding states of Massachusetts, Connecticut, which we believe is possibly attributed to some of the dye industries and jewelry industries in the area. More information to come.
Thank you.
I have a question, Trish.
Yes.
If you have a lot of other GI issues, you have a higher risk of having colon cancer?
Well, so like I mentioned in the discussion, there are certain disease processes that do increase your risk for colon cancer. And those include what we call the inflammatory bowel diseases. You may have heard of that, Crohn's disease, ulcerative colitis. Those are the two that significantly increase the rate specifically for colon cancer.
Or like pancreatitis?
Pancreatitis?
Yeah.
No, not pancreatitis. No, there's no associated increased risk for colorectal cancer.
Okay.
Patients with pancreatitis or IBS or reflux disease, constipation either. No.
Okay,
not.
thank you.
You're welcome. Okay. Any others?
I have a comment.
Okay, thanks.
My grandfather died of colon cancer. And I've had the screenings, since I was 50. And several of the times they've taken out polyps. And I think it's great. That's an easy way to avoid what happened to my grandfather.
Yes, absolutely. It's
Yeah.
a life-saving procedure for sure. I mean, I can say even within the past, week or two, I have, detected patients with an early cancer, but even early enough to get into treatment, and it makes a big difference. And I mean, polyps, we see that all day and every day, so there's no telling how many lives have been saved just by that one procedure. Well, thank you guys. Thanks for all of your attention.
Thank you.
Thank you so much, Nnenna and Mariam. We really appreciate it.
Thanks for having
Thank
us.
you. And thanks to all on Zoom for staying.
All right, so wear blue to support colorectal cancer. It's a lovely royal blue.
Yeah.
All right, so if you have clothes in that color for the month of March, feel free to join.
Thank you.
Thank you.
Thank you.